Thank you, Sue, and thanks everyone for taking the time from this beautiful afternoon to join us. So we'll talk about strokes, and I'm going to talk a little more about strokes and why they happen at a young age. So before we do that, let me just go over something that we call a stroke or a heart attack, just the differences. These are all in the same category of what we call vascular disease, which is blood supply is either cut off or reduced. When it happens to the brain, we call it a stroke. Obviously, if it's heart attack. And in the extremities, like in the limbs, we call it peripheral artery disease. But the underlying factor here is common to all. It's a common theme, which is the vascular disease, which when I talk about the risks and the effects, we're kind of covering all these topics at once, although I'll be focusing mostly on strokes. So to give you an estimate of the strokes, in a year, about 800,000 strokes every year. There are more than 1 million people alive today with strokes, more than 150,000 deaths, unfortunately, due to a stroke. And as you can see, every 40 seconds, there's a stroke. It still leads the way in terms of the number of disability from functional impairment, and it is one of the top causes of death as well. And obviously, why we want to talk today is to prevent a stroke, and primary prevention is important because more than 70% of the strokes are first-time events, and these are preventable. So let's talk about strokes in young age. And we kind of consider people who have strokes are mostly older, have a lot of things going on, but it's not any longer true. We are seeing a lot of young folks with stroke, and our awareness of stroke, so to speak, has also improved. And it should be noted that, we see an increase in stroke as age doubles. For every 10 years, the risk of stroke doubles after 55. But there's been a recent increase in strokes in the last 10 years in even people younger than 55, more so like 44% increase. And about 10 to 15% of strokes occur in very young folks, actually 15 to 49. This includes the adolescents and young adults. So there are many causes for stroke, but we're seeing that more and more often, the causes that seem to be occurring in older folks or in folks who are having traditional age for strokes seem to be occurring more in younger folks as well. And this is kind of catching up with those risks, so to speak, which is, obesity, high blood pressure, and diabetes. And this is kind of a confluence of what we call the metabolic syndrome, which is becoming more common in younger groups. Add to that lifestyle, which includes smoking, heavy drinking, and that's another increased risk of stroke in young folks. Now, this is, not just common in any age group, it's kind of increasing at every age group. And this is not just in the US, but across the world. So what can cause strokes in young? And there are some more specific causes, like less frequent causes, such as a tear in the neck. This can be from something called a dissection, can be specific arterial conditions, like, for example, an inflammation of the artery, like lupus. There can be some clotting conditions. There can be certain genetic conditions. But as you go along the list of conditions in young people, when it comes to genetic causes, it becomes less and less frequent. But having a family history of strokes is important, and I'll tell you why in a minute. But it's good to know that, just because somebody in the family had a stroke, it doesn't necessarily entail that one has to have a stroke again in the family. So there are less genetic factors and more predisposing factors to stroke. There are certain heart conditions in young folks who can have strokes, and these are due to a condition that can lead to a clot that can travel up to the brain from the heart. So there are specific conditions that cause this, even in young people. We've seen this. Certain heart rhythms that can only be detected by doing, say, a monitor or an EKG. This is called atrial fibrillation or atrial flutter. Now, these are irregular heartbeats that can increase the risk of stroke by causing clots in the heart. And one may not know this, and it may be some folks may feel a funny heartbeat, some folks may not. So it's very important to have this checked out. And we do this testing usually in strokes, but it's also important to look for those when you see a primary care doctor. So other things in young folks, heart conditions. So there is a recent interest in this condition called a PFO, which is technically called patent foramen ovale, which is the long form of this. It's a small communication that most of us are born with. It closes soon after life, but it tends to persist in a large population. 1 in 4 people have a PFO, this communication in the upper chambers of the heart. But not everybody with a PFO goes on to have a stroke. And by and far, not all strokes are from PFO. That's another thing to be noted. So young folks who have strokes, we tend to do what we call a collaborative approach to decide who gets to have this hole in the heart to be closed, and is that really a culprit? And those are things we really look for in young people. So it's not just about looking for those things, it's also asking the right question. Is this the real cause, and can we attribute it? So we have a great team here to look into those. We have a group of doctors who belong to our clotting disorder specialists, our cardiologists, and us neurologists who put our minds together in every single patient that we see. So these are all the things, of course, that take a lot of workup. And obviously, I'm not going to get into too much details, but these are things that we do when we see people with strokes at a young age. Now, we will have another lecture about women at young age and strokes tomorrow, but there's been an increased instance of women with strokes at young age, more so of clotting strokes. And we've noticed a trend that, can happen, especially in women who take birth control and smoke. And so very important that, women don't smoke when they take birth control pills. And of course, if you have a clotting disorder in women, it's good not to take the birth control pill without specifically asking your primary care doctor or your gynecologist for that specific advice. Now, there are other things that will be covered in the topic later on, but most strokes in women can be, from these kind of clotting disorders. And so it's very important to look to see what predisposes one to clotting and whether or not you're safe to take a birth control. The other things that happen in young age is aneurysm. So aneurysm causes a stroke by the mechanism of bleeding. Unlike clotting, it's a sudden onset of a headache in somebody who's never had a headache before, and that could be a sign of an aneurysm. And aneurysm in young people is kind of something you want to look for and may run in the family, not always. And it's very important if you do have a family history of aneurysms, such as bleeding aneurysm in the brain, very good question to ask your primary care doctor. Do I need to be tested for it? Do I need to have a scan for it? And that's a very good question to ask your doctor. So something to look for in young people. And we always consider this to be also correlated sometimes with high blood pressure. So a lot of my discussion today will revolve around hypertension or high blood pressure, but this is something to look for as well. So we're going to talk about signs and symptoms of stroke, but before I do that, I want to talk about heart attack. When somebody gets a heart attack, you have this classic, it's like an elephant sitting on your chest. You have this pressure, this tightness, this fullness. Not all people have this kind of symptom. Some people can have some strange, jaw pain or neck pain that doesn't want to go away, or shoulder pain, or kind of pain radiating into the shoulder or into the neck or into the arms. Or it can be just sweatiness and feeling woozy. So those can be all symptoms of heart attack. And why I bring this up is, heart attack has this pain that sometimes comes along with it. But with stroke, you don't have that pain very often. Strokes are very often not painful. Less than 10% of all strokes have a headache. Most of the strokes don't come with a pain. So it's very important for us to not only recognize stroke when it happens, but also be on the lookout for your loved ones or bystanders. So if you look at the population in the US that an ambulance is called, very often it is the bystanders or the people who are beside them who call the ambulance. And that's because of the knowledge of understanding when a stroke happens. And these are the symptoms. So anybody who has sudden onset of balance, loss of balance, staggering, eye problems. So it's the mnemonic called BFAST, as you can see, trouble with seeing out of one eye, loss of vision. The other thing is obvious, it's a facial droop. Arm drift, where you can't lift your arm, or when you hold both your arms up in the air, one of them drifts down. The other thing is a speech problem, which can be slurred speech, can be trouble talking, can be trouble understanding, can be both. And very often people may appear confused, and that's because they may not understand the language they're spoken to, or they may not be able to speak what they mean to speak. So that's another sign of stroke. And obviously, headache, like I said, is not a common symptom, but if you get a headache that is new and sudden and has not happened before, and there's no specific cause, it's time to seek action. And that's when any of these things happen, don't wait, call 911. And that's the important thing that we'll be talking about today. So I want to elaborate a little bit more, and I'm kind of repeating here. The symptoms of stroke, again, drift, arm weakness, leg weakness, numbness. So if somebody says I'm having numbness in my arm and my leg, I'm going to wait around and see what happens. And the answer is no, that's not a good idea. That is going to get worse, and you might be out of the window for treatment, because we have what we call limited windows of treatment. So do not wait for them to get better. It may not. It may in fact get worse, and there is treatments to prevent those from getting worse. So always seek help, even if you have like numbness on one side that seems to want to go away, but you still should seek help. Confusion, trouble understanding, I just spoke about that. And obviously, dizziness can be a lot of things. It can be, low blood pressure. It can be, a lot of other possibilities. But something that is new, sudden onset, something that makes you lose your balance very quickly, you're staggering, you're kind of, tipsy. It's very important to seek immediate attention by calling 911. So why is it important to call 911? And why should we call 911 and not just drive up to the hospital? It's good to know that 911 sets off a motion that takes place from the time you call 911, from the dispatch to the time the ambulance arrives, to the time the ambulance takes you to the hospital or takes your loved one to the hospital. It's all about keeping that connection from the time it happens to the time you get in. So faster action includes, having an ambulance come to your place, take you, and time is the worst enemy. And when we look at time is brain, and death and disability increase the longer we wait. And by calling 911, you can get the attention by coming right into the hospital. So I'm going to talk about what happens in a stroke. When a stroke happens, a person loses the function, like I mentioned, those symptoms. And when that happens, it's an interruption to the blood flow to the brain. And that's called a clotting stroke. Or it can be a burst or a rupture of a blood vessel, and that's a bleeding stroke. Now, either strokes can present with the same symptom, which is weakness, numbness, and all the other symptoms that I spoke about. And there can also be another thing called TIA, or a mini stroke, where people can have those symptoms, short duration, and can be just a mild weakness that tends to go away, but it kind of gives you a false reassurance that you're doing well. In fact, it is a warning sign of a bigger stroke to come. So always keep that in mind. If you have something that kind of comes and goes, it may be a sign of something serious to happen. And as you can see, about 11% of the patients with TIA end up having a stroke in 3 months, but vast majority of those patients who end up having a stroke happen to have it within the first 2 days. So very important to call 911, even if your symptoms have gone away, because they need to bring you in. We need to do those assessments very quickly and make sure there's nothing going on there. So these are, most of the time, we may not find a brain injury because the blood supply comes back very quickly, but it is kind of like a harbinger or a warning of a stroke to come. So talking about the types of stroke, about 85 to 87% of all strokes are what we call clotting strokes, meaning a blood clot either migrates or forms in the artery, cuts off the blood supply to the brain, and leads to those symptoms. Less often, it can be a bleeding stroke, say within the brain or outside the brain, for example, an aneurysm. And those bleeding strokes tend to cause the same symptoms, as I said, and the only way to tell is to do a scan of the brain. So that's why it's important to come to the hospital right away to tell the difference. So when we say patients who come to the hospital by calling 911, they come by ambulance or they come in, they should not take an aspirin because, when you take an aspirin, the clotting stroke may or may not be helped, but the bleeding stroke can definitely get worse. So, we always say skip the aspirin, call 911, come right to the hospital. So this is an example of a bleeding stroke. When you have somebody who has a bleeding stroke, we can see it on the CAT scan as a bright spot, like I've shown here. This is a CAT scan that is kind of a slice across. You can see the ice in the front. So that's kind of what we see. Typically with a bleeding stroke, we see it right away, and we can even tell what location, what is it likely to cause, and most often than not, we kind of watch them very closely, tend to control their blood pressure, and keep them supported so they don't develop complications. So when it comes to acute stroke, we not only do these scans, but we also do what we call a telemedicine evaluation. Within 5 to 10 minutes of somebody arriving to the emergency department, when somebody has a stroke, we have the ability to connect very quickly to specialists. Specialists like us, neurologists, who can look at the patient, who can evaluate them very quickly with the help of the nursing and emergency department, and can make decisions very quickly so that we don't waste time in saving brain cells. So here we have an example of a clotting stroke. When we get this kind of clotting stroke, we can quickly see a clot is happening in the brain by doing what's called an angiogram or a dye scan. And we can see there's no blood supplied to this part of the brain, whereas this part is getting its good supply. So this is kind of a clotting stroke that we see that is likely to progress to becoming a full-blown stroke if we don't act quickly, meaning trying to open up the clot either by the way of medications or by going through a catheter device that removes the clot. So what is this part of the brain that controls it, that has clotted, as the part that controls the bodily function? It has to do with the speech, it has to do with your hand, your leg, and ability to move, walk. And this is a part of the brain that's affected in that example. And these are very important functions in the brain. And what we aim to do by trying to get the blood supply back is not just about getting the blood back to the brain, but to prevent and reduce both disability and death in the long run. So very important to come right away. So what can we do to prevent or to break up the clot and prevent disability is using this clot busting medication, which we can give within the first 4.5 hours of a stroke, which is usually given through an IV line, which is a small needle that goes in the arm. And following this, we do something called a clot removal, which is basically putting a catheter like a snake, snaking a small guide wire and a catheter up through the artery in the groin. This is a minimally invasive procedure that goes all the way into the artery of the brain. And then we snare it with this device and bring it all the way out. So not always does the clot buster medication work. And in some cases, we follow up the clot buster medication with this clot removable device, which in this case is called a stent reaver. This is a landmark device after 2016 onwards, where most of the hospitals have been using this to improve stroke circulation and decrease disability. And obviously, we've seen a significant and drastic reduction in deaths due to stroke from this. So in this case, as you can see, this is the front, and you can see the small catheter that goes up to the area where the clot is. And you can see the clot is barely supplying the brain on this left side. And then once the clot is taken out, you can see how smooth and nice the blood flow is restored back to the brain. So this is one example of how clot busting medication, as well as ways to improve by removing the clot, works to improve outcomes. And we've been seeing a lot of good outcomes because of this breakthrough technology. And one reason why we call 911 to get these patients into our hospital quickly. The other thing we also look for when we do these studies is to look at what's called the carotid artery. As I mentioned before, carotid artery sometimes can be a cause of stroke, like a tear, but more often than not, it is due to a plaque. So sometimes people come to us with like a transient something, like a transient weakness or a transient speech problems that comes and goes away. And we look for these kind of things. And when we find a carotid artery plaque or a clot, we tend to treat them by stenting or operating on the artery. So this is kind of a pictorial of the same before and after the stent was put in. So same thing in the depiction. This is a plaque in the artery, and this is another common cause of stroke is carotid plaque. So we look for those when somebody comes in with a clotting stroke. And why is it important to know this? And the incidence of this is increasing even in young people. So it's very important for us to look for these things. Besides plaque, as I mentioned, a tear in the artery can also cause a stroke in young folks. So we also look for those things. And then coming to the bleeding stroke, as I mentioned, in this area, as you can see, the bright spot. So bleeding strokes tend to also be quite devastating. But if we support them, we treat them, we get the right rehab, they tend to improve. And typically that's the motto is to try to get them taken care of with their blood pressure and take care of their bleeding strokes. And the strokes that are with just the headaches, as I mentioned, which is not very common, but these are worst headache of the life, can be due to something called an aneurysm. As I mentioned before, any age can have an aneurysm. Young people can have aneurysms. Older folks can have aneurysms. So there's no age to when this can happen. Any sudden headache that has never happened before, or it's a worst headache, it's always important to seek immediate attention. And oftentimes we may find that there is an aneurysm that burst, causing the blood to cause the brain to be, hurt or harmed. And we want to prevent that from getting worse by the way of going through those same arteries, like I mentioned before. But this time around, we put something called a coil, or we clip them. So that's another thing we can do pretty much immediately after patients come in for this kind of a bleeding stroke. So we're going to change gears from treating to preventing them. And when I say preventing, 80% of all strokes are preventable, and you must realize that 70% of all strokes are first-time strokes. So when I talk about prevention, it's not about just preventing first time, but all strokes. So that's very important to note that there are stroke survivors, there are stroke people who never had strokes, and anything we do to prevent goes a long way in not only preventing strokes, but also in preventing heart attack and vascular dementia. So what can we do to prevent those? We call them risk factors. So we want to treat those risk factors, but when we want to treat and recognize them, it's never too late to treat them. And always get to finding out what those risk factors are, because it is very important, not just in stroke prevention, but also in heart attack. And like I mentioned, the progressive form of memory loss called vascular dementia, which is a less likely cause than Alzheimer's, but it is also catching up to our increased risk of hypertension and other risk factors, so to speak. So what puts one at risk for stroke, heart attack, or vascular disease? And we're going to talk about two topics, things that cannot be changed, like age. As I mentioned before, for every 10 years, we're kind of increasing the risk of stroke or heart attack, and that we cannot change. Sex, there are younger women have increased risk of stroke from certain conditions. Obviously, there's a lot of racial disparities. Family history, like I mentioned before, it does not necessarily mean that if somebody in your family has a stroke, it is always a guarantee that somebody has to have a stroke in the siblings or in the kids. But it's always important to know your family history to be able to address what we can treat. The other thing is past history of stroke or heart attack can also put somebody at risk for stroke, but the good news is they're also preventable. So what can be changed? There are risk factors that we can modify, and these are totally under our control. Physical inactivity. So physical inactivity and high blood pressure are the two main topics that we can prevent to prevent a stroke. And if we take action to try to be active, to improve our steps, as 7,000 steps, so to be precise, from the data, and trying to be less sedentary goes a long way in getting rid of the other things down the road, which is heart attack, stroke. Obviously, if it's obesity, it also is good to lose weight. And I'll be talking about all this in a more great detail, but I want to pay more attention to high blood pressure, and stress as well. So let's talk about specific conditions that increase the risk of stroke. And there are very specific causes, like I mentioned before. One of them is called atrial fibrillation. And this is a condition in the heart that increases the risk of stroke. And this condition can increase with every decade. And your doctor will be able to tell you if you have this rhythm or not by doing a simple EKG at bedside. The other thing is carotid artery disease. Some people can have a TIA. Atherosclerotic disease can put you at risk for carotid artery disease. And last but not the least is sleep apnea. And you might have heard about sleep apnea in different ways. It's not snoring that is sleep apnea. It's about trouble breathing in sleep. Not all people who snore have sleep apnea, but sleep apnea can be associated with snoring. And when you look at sleep apnea, it's a trouble breathing and not getting either enough oxygen in or your sleep is interrupted, leading to poor quality of sleep. So this is another risk, and there's this gender difference as well. It is increasing risk in men more than women. It also increases risk of high blood pressure across all spectrums, be it men or women, young or old. It can increase risk of irregular heart rhythm. The first one, as I told you, atrial fibrillation, increased risk of heart failure. So if you don't get quality sleep and you wake up and you feel foggy and you feel tired, it's a good time to talk to your doctor about getting a sleep study. And that's one thing that is highly connected to high blood pressure. So for example, your doctor is trying his best or her best to get the BP under control and it's not budging. And you're not getting good sleep. Maybe the answer is in the sleep apnea. So ask your doctor to get a sleep study. And it can be as simple as getting it at home, which is a home sleep study. So the other thing we can do to prevent stroke and heart attack is risk factors, and I'll keep going on this, knowing your numbers. So I'll be talking about a lot of numbers here, and I don't want us to be able to memorize this, but it's kind of one of those things where you want to pay attention to these because you can modify them. One of them is physical activity. 30 to 60 minutes. American Heart Association has brought a new number, 40 minutes, but no matter how much time you spend, it's all about making it quick, brisk, and walking often makes a big difference. And even if you don't have a dog, walk as often as you can. Of course, for people who cannot walk, it's very important you can do other exercises like hand exercises, stationary bike. If you have arthritis, water aerobics, all those have a long ways to go in helping improve that blood pressure. What about nutrition? We've heard a lot about heart-healthy diet, the Mediterranean diet. All that is true. Improving fiber in your diet is very, very important. Nuts and legumes is what the AHA recommends. Increasing your plant-based diet, reducing high saturated fat and animal diet is a good idea. Reducing processed foods is very good. And that also goes a long way in reducing both obesity and high blood pressure. Smoking is another thing that's very important. And if you smoke, today is a nice day to quit. And if you don't start. Now, no matter how long you quit, or how long you've smoked, how many times you quit, it's always good to quit. A lot of folks quit many times before they finally quit. So you're not alone if you quit and you come back to smoking. It's always good to keep trying. And oftentimes it takes 2 to 3 years for a person to quit, to be no longer at risk for heart attack or stroke. And your risk decreases as soon as you quit smoking. And after 1 year, that risk decreases significantly. And the elephant in the room is the high blood pressure. So why I say that is more than 50% of all the diseases in the world are due to high blood pressure. And this is kind of catching up very quickly across the US and across the world. What is normal blood pressure? 120 over 80. Anything higher than that could be harmful. We like to keep the number below 140, 90. That's kind of our go-to number. But your doctor will know what the right number is. Suppose you have diabetes, or you have heart failure, or you have kidney disease. It may be better off to get that BP even lower, closer to 120 over 80. So it's always important to ask your primary care doctor, what's my blood pressure and what should be my goal? The top number on here is called the systolic, and the bottom number is called the diastolic. Both of them are very important to keep in mind. And both of them being elevated can have a significant risk in heart attack, stroke, kidney, and eye, and also with, like I mentioned before, vascular dementia. So getting a BP under 140/90 should be our top priority. What else can we do to get that BP down? I mentioned about sleep apnea. If your BP is not getting down, think about that. What else? This is new, and this is kind of a study that came out last year in the Journal of Heart. And we're seeing more and more that our sodium consumption is directly linked to high blood pressure. What can we do about it? Look at your labels. Try to keep it below 2300. So when I say 2300 milligrams, that's a very unusual number, but this is what the American Heart Association says. For most adults, keeping it under a teaspoon, preferably half teaspoon, is what we recommend. Whole fruits, whole vegetables, unprocessed foods have no sodium, so you want to increase that. But when you do want to consume that is pre-packaged, make sure you look at the package label, make sure you look at the sodium, and make sure you keep it below 1500 if you can. Especially if you have diabetes or heart problems or stroke, it's very important to get that sodium goal less than 1500 milligrams so that you don't have hypertension or you don't have trouble controlling the hypertension. And if anything, this is one very important thing to keep in mind when it comes to diet. And we're seeing more and more, even the simple things that we eat have a lot of salt. So keep that in mind to take home with you to check those labels. The other thing that is also important is cholesterol. There's something called a good cholesterol, bad cholesterol, and total cholesterol. You want to ask your primary care doctor, what's my cholesterol number? What does it look like? And it's kind of a profile. Your good cholesterol should be less than 200. HDL, also called healthy or good cholesterol, less than 40. Total cholesterol less than 200. And then there is another cholesterol called LDL. It's not exactly lousy cholesterol. It's also called low density lipoprotein in technical jargon, but we call it lousy cholesterol to keep a better tab on this. And our goal should be less than 100, but less than 70. But I want to be as non-specific here as possible because each person's goal is based on what they have. Do they have heart attack? Do they have diabetes? And there are guidelines around it that your primary care doctor, your cardiologist, your neurologist, your specialist will know to keep those goals. Again, it's very important to know those numbers, but it's also important to know that these are modifiable with diet, exercise, and medications. So it's good to know that you can modify these numbers. What else can we do? Diabetes. If you have diabetes, it's good to control it. But what's important is if you have diabetes, look for other things to control and control them much more vigorously. In the sense, you want to, when you have diabetes or somebody has diabetes, you want their blood pressure to be much better controlled. So when I bring up diabetes, I must also say that diabetes is not seen in just older folks. It's catching up in young people. As you can see, the body mass index, also called BMI, is increasing, and so is diabetes and hypertension. So it's very important to not only control high blood pressure, but losing weight, stop smoking, and regular exercise makes a big difference. One more thing is type 1 diabetes, that is diabetes wherein the pancreas does not create insulin, can also be at risk. So it's also important to get the sugar under control, but also important to know that this can happen at a young age. And you're not alone. There's a lot of people with this disease. And it's always good to keep your diabetes specialist, your primary care doctor, and keep following up with them to make sure the numbers look good. There's a lot of data about alcohol. I know there are some data about, if you drink, it's good for the heart and other things. But if you don't drink, do not start drinking. It's a good idea to stay away from it if you drink. But if you do drink, make sure you cut down. Not more than 2 drinks per day for men, no more than 1 drink. When I say drink, it's not whiskey, it's beer for 2 drinks for men. So keep in mind that it's not just the alcohol consumption, but also alcohol percentage. So keep it light. There have been increased reports of alcohol downstream effects on the brain, on the pancreas, on the liver, on the stomach, on the esophagus. So we're seeing a lot of other issues. So if you don't drink, good idea, stay away from it. But folks who do drink, please seek help. If you can't get off of it or you can't reduce, please feel free to call your doctor. There is a lot of support groups to help you. Another important thing, stress. So what is stress? And many of us can't really measure stress. And, many of us think that stress is, something that is big, like you're making a big purchase or you're making a big decision in your life. It's not always the case. It can be a lot of small things. It's the small things that accumulate over life that can actually increase the risk of stroke and heart attack. And the way stress works is indirectly, in a sense that increases the risk of hypertension over a long period of time. And there have been some studies, this is not specifically to women, but there have been some studies in Japan in women who report high levels of mental stress, who have had what we call heart attack and heart problems, where the heart has undergone structural changes. So when you have a stress, you want a way to relax yourself, and finding your Zen is something entirely up to you, but a lot of people do differently. Some people like to take a walk, and I'm not talking of just after your work. It can be during your work. It can be at work, trying to meditate, find the right things to relax or ponder upon, and maybe even taking that quick stroll outside, or just casually having a conversation, sharing your experiences. All that can help you relax. And I can tell you there's one study that looked at this, and that study looked at folks who had had spent some time, say 15-20 minutes of their time, just caring for their pet like a dog or a cat. And there was a significant 10-point decrease in their blood pressure within that same time period. So it's a lot of things. You can have a four-legged furry friend who can be your de-stressor. So, finding your Zen is very important, and not everybody fits the same, kind of profile for stress relaxation. So, talk to your doctor, talk to your therapist, if it's applicable, but keep in mind that you can't fix certain things. So don't sweat the small stuff. So once again, it's not too late to take action. Even if you're young as 15 or 18, just talk to your doctor, ask your doctor about those numbers, and it's never too late. And always know that you have risk factors, and it's not just about you, but also asking your family those questions is very important that you can bring to your doctor. Once again, coming back to stroke, and why is it important to call 911 is because of this, kind of stream of connections between where the stroke happens to the hospital. We're kind of like an integrated system where the EMS tells us that a patient is coming in, make sure you recognize the signs of stroke, and that they get their medications as quickly as they can if they're eligible, and they get to having a better outcomes. And that's why it's very important for us to know those symptoms, call right away. And last thing about TIA, like I mentioned, these can be short-lived. A lot of folks, I know I'm repeating myself here, a lot of folks tend to wait it out. They can have something as mild as a numbness or a weakness or trouble walking. They just want to, it just went away after 10 minutes, and it gets you a false sense of security. Don't wait. Call 911, even if it has gone away. So again, I'm kind of repeating myself, but it's very important. Why? Because about 2 million neurons die every minute. The faster we take action, the better it is. So for every 10 minutes of delay, one patient is disabled, one extra patient gets disabled in that first few hours of a stroke. So very important for you to come in right away and get the blood restored and take care of it. And you must realize that we have up to 24 hours with big strokes to take care of, but don't wait 24 hours. Even that 2 hours, that first hour, very important. Come in right away. Now we're going to change gears to see what can we do once somebody already has a stroke. And I can tell you that a lot of people are stigmatized that they have a stroke, and there's nothing more important than treating with rehab and recovery. And why are we worried about strokes, and why is there a stigma? Is because you can see the effects of stroke, unlike a heart attack. You carry the effects. You must realize that there are two good things that come out of this. One is you get a lot of attention from your doctors. You are getting the risk factors controlled. That means your risk of heart attack, your risk of dementia, your risk of getting other complications are much less when you have had a stroke and you seek all this attention. So make sure that you follow up with your doctor and get those medications. But also after a stroke has happened, make sure you get your rehab and make sure you get your recovery. Most people who have a stroke make a lot of meaningful recovery. Here I quote about 60 to 70%, but time is of the essence. A lot of people tend to worry that they're seeing a lot of disability right up front, but it takes time. I typically say about 3 months, but it can take even up to a year, even up to 2 years. So it's always good to give it time, give it a lot of space and rehab specialist opportunity to work on stroke people to get you better. And obviously, there are some really devastating strokes that can affect the body, but most of the time it takes time to recover. And as I've noted here, a small percentage recover very quickly, and the more likely they are to get their blood supply back, the more likely they're also expected to recover within the first 30 days. So even if you get your clot buster medication, even if you got that catheter to remove the clot, don't be under the feeling that you're not going to get better because you're still having the effects. You must realize that the effects kind of tend to appear a few weeks later, if not a few months later. So the road to recovery can be long, but it is always important to keep your rehab on your side. When a stroke happens, it can be any number of things. It can be memory, it can be weakness, numbness, it can be balance issues, it can be trouble coordinating. So there are a lot of things that can be affected. And very often we have a group of people who specialize in those services. We call them rehab specialists. These are people who are as qualified or as trained as we are to take care of those patients who have strokes. So we have different types of rehab. When somebody comes to the hospital, we discharge them to a rehab facility. And it is very important to know that patients who have a stroke, when they go to a facility, it's not a bad thing. It actually is a very good thing because they're getting extensive therapy. And when you go to an inpatient facility, you're getting about 3 hours of intensive therapy, PT, OT, and speech therapy. So very important to know that after a stroke, if you're going to inpatient rehab, you're going to make a very good recovery because you qualify for rehab. And then there is also homebound therapy. There's also outpatient therapy for less severe strokes, people who can return home to their family. We want that to happen. We encourage that. And then there are people who are not as able to do those things and they go to nursing homes, but they still get rehab. So, there are so many ways to getting rehab. And these are all the examples of how we can get that rehab. But where does rehab start? It starts right in the hospital on day one. When they come to the hospital, they get this treatment. As soon as they're safe to start, we start physical therapy, we start speech therapy, we start the rehab right then, right there. So very important to know that rehab is an integral part of stroke recovery. What are the kinds of rehab? It all depends on the kind of stroke. So if the stroke has affected your bodily function, such as walking, your ability to do certain tasks like range of motion, that is movement of your arm, your leg, physical therapy comes into play. Occupational therapy is when you have to do certain activities like feeding yourself, taking care of your day-to-day activities, making those cognitive changes, which has to do with high-level processing to do certain tasks, such as returning to work in a high-level environment. All those occupational therapy can help. They can also help you with visual therapy to prevent falls. Speech therapy, very important. They talk about, so when I say speech therapy, it is not about speech alone. It can also be about memory. It can be about your cognition, which has to do with processing in the brain. Some people can have delayed processing. Some people can have trouble getting the right words out. Some people can have trouble using those words or using those skills, applying them. So all that is, part of speech therapy. And then we also have recreational therapy. And part of what we do at Baystate is something that we like to involve is, a lot of trials that we do are focused on rehab. One of my colleagues actually looked for that is, singing, music plays a big role in recovery. And, if you have a hobby like cooking or gardening, that's very important to get back to doing because that also is a part of your stroke recovery. There's a lot of websites. I want to bring your attention to the AmericanHeart.org, which is the website we often refer to for guidelines. If any of you want to get into more details about the diet, about high blood pressure, cholesterol, or what you're doing right and what can you do to prevent a stroke or heart attack, there's a whole wealth of information on this site. And obviously, it's very important, and I cannot stress this enough. Time is brain. So if you notice somebody having a symptom of stroke, don't wait, just call 911. And obviously, like I said, skip the aspirin because we want to get them in, get a scan, make sure they're not having a bleed before we give them the medications. And if you don't understand what's going on with somebody, they're not acting right, call for help. When you call the 911 dispatch, you don't have to make a diagnosis of a stroke. You just have to tell them what's going on. Something is not right. And when you call 911, the dispatch agent is going to stay on with you. They are trained to tell you what is a stroke, what's a heart attack, and they can walk you through the whole thing. So, like I said, something suddenly happens to somebody, you're there on the scene, just pick up the phone, call 911, or call for help because you're saving a life. And that's a big difference for somebody's life, their disability. And, obviously, that's my last slide. So if you have any questions, I can now take them. But I hope you all enjoyed the show. And I hope, we've made a difference in recognizing symptoms of stroke and, we can save someone's life today. So thank you so much for your time and attention.
Thank you, Dr. Padmanabhan. That was an excellent, comprehensive lecture, and I appreciate your time and expertise. There are a number of questions that we can try to get through before the end of the program. The first one is from Bob. My father died of a heart attack at 59, so I have concerns about heart and stroke conditions. What kind of testing can I do to be proactive about stroke? Also, do you recommend a baby aspirin daily?
Yeah, very good question. And I'll come to the second question in a minute, which has become a controversial question recently. But the answer to your first question, I think, is excellent. When somebody in the family has a stroke or a heart attack, it doesn't necessarily translate directly to the genes, but it is important to know that those mean that your primary care doctor, your doctor that you see every year, needs to look for certain things. So, for example, what do you ask him? What's my blood pressure number doing? So, blood pressure or hypertension is the number one cause of stroke and heart attack, or risk factor, so to speak. So do check your blood pressure. If you have a cuff at home, it's good. But more often than not, ask your primary care doctor. And then know your numbers. What's your sugars? What's your cholesterol level? And are you getting those steps every day? And your doctor can also specifically look for EKG to look for symptoms of heart irregularity. Like I mentioned, changes on EKG can show up very quickly. It's a bedside EKG. You can ask him to get an EKG and also ask him or her to go over your diet. And, if there's something they can do, it can be, like I mentioned, looking at the sodium in your diet, looking at the salt in your diet. So that's very important. If any take-home message I can give to our audience today. Now, talking about the second question, and that's the question I didn't address today on my talk, and I wanted to very badly, and I'm very glad that somebody brought this up. So thank you, Bob, for that. Now, does aspirin really prevent strokes and heart attacks when somebody does not have a stroke or a heart attack? There is a recent study with more than about 60 or 70,000, if I remember correctly, of group of people who took aspirin. Now, we must realize that about 20, 30 years ago, aspirin was recommended for young people and old people alike. And aspirin was felt to reduce the risk of heart attack and stroke and also reduce the risk of colon cancer for some reason. And this recently just came out and said, well, if you're 65 or older or above 60, your risk of bleeding is higher when you take an aspirin and may not be worth it. But if you're below 60, talk to your doctor about whether or not to take an aspirin. Now, I must warn you that this applies to only people who never had a stroke or a heart attack. So if you're below 60, you're a young person, and you want to take an aspirin, that's entirely dependent on what your risks are. And for me, it may be diabetes, peripheral vascular disease, or a family history might promote me to put somebody on a baby aspirin. But that may be dependent highly on those numbers that I look at with my primary care doctor. So I cannot have a one size fits all. But I can tell you that people above 60 did not have any benefit and had more bleeding. So the risk benefit kind of decreases over age. But I must warn that this is only for people who never had a stroke or a heart attack. So if you're advised to take an aspirin for a stroke, a heart attack, or some other thing that your doctor has given you, do not stop your aspirin. Very important to talk to your doctor and continue this aspirin, because that aspirin is what protects you and prevents a stroke and heart attack. So, the good news is giving everybody an aspirin may not work, but the good news also is people who are already taking an aspirin for stroke are preventing a heart attack. People who are taking aspirin for heart attack are preventing a stroke. So it's kind of all connected, but the answer is not as simple anymore, where aspirin prevents a stroke or a heart attack. But obviously, people less than 60 are good candidates if they don't have bleeding risk, and if they can do what's called risk stratification. More technically speaking, there's something called a Framingham Heart Score that tells you that aspirin may be beneficial. This is a Framingham study that was done in Framingham, of course, for 30 plus years. And your doctor can use that calculator to come up with that risk score and can tell you if you need an aspirin. So very good question. And I hope I answered that question.
Thank you. I think you did a great job. We still have a number of questions to get to. The next question is, do you recommend calling for an ambulance if one lives 15 to 20 minutes from the hospital? We live in Leiden. It's about 8 miles from Greenfield. That would be Baystate Franklin. And what is your recommendation on that?
Yeah, no. So here's the deal. So in Massachusetts, which is the leader of the rest of the country when it comes to stroke care, stroke systems of care have been organized since 2 decades ago. And Massachusetts leads the country and the world actually in terms of stroke systems. When you call 911, actually the state requires to tell the EMS agencies to get you to the closest stroke certified hospital. And those stroke certified hospitals are usually within 20 minutes. So you don't have to find a map, get on the GPS. The ambulance does that for you. Suppose there's a construction between Leiden and Greenfield, and the ambulance knows that, they'll take you to another hospital that's close by, for example, Cooley Dickinson. So very important for you to know that these are ingrained into the EMS care networks, which is why we tell people not to drive to the hospital, because EMS does the distance, does the mapping. And these are built by the stroke Department of Public Health policies, where when somebody calls 911, which hospital should they go to? Where is the care? So Franklin obviously is a stroke certified hospital. So are all the other hospitals in the valley, Mercy, Noble, Wing, and Baystate, of course. So very important to know that all these hospitals are certified. So the ambulance knows to take you to a stroke certified. When I say stroke certified, we're required by law, by Department of Public Health, by the Mass Public Commission, to be able to prove that we provide quality care. We report that statistics to the general public. You can Google them online. We report our ability to provide sound care. We report our ability to prevent death and disability. So all that is built into our system, and that's what Massachusetts excels in. So if you're in Boston and you're in, say, Needham or Foxborough, you get the same care going to Mass General as if you are in Leiden and going to Greenfield. So that's because of the state requiring us to be highly proficient by certifying ourselves. So you must rest assured that no matter what hospital you come when you call 911, that hospital is certified to take care of the stroke.
Awesome, thank you. Next question, Carol Lee would like to know, after having a cryptogenic stroke, what is the likelihood of having another bigger stroke? Is it a warning?
Very good question. So I didn't bring up the word cryptogenic today because I thought it was too technical. So very good question. So cryptogenic means there is no cause found. And I wanted to tell you that about 1 in 3 people, or I should say 1 in 4 people, don't have a cause. And what do we do about those cryptogenic strokes? Well, there's a lot of research going on right now. You're not alone. Right now, what we do in cryptogenic strokes is we keep looking for certain factors. For example, the PFO, the communication in the heart, if you're young. And if you're not young, we also look for something called atrial fibrillation, the irregular heartbeat, which happens to be a small percentage. About 1/3 of all cryptogenic strokes happen to have AFib. So what we do for those folks is we put a cardiac monitor and send them home. and we detect to see if they have what's called an irregular heartbeat called AFib. Now, I want to tell the general audience that not all irregular heartbeat is AFib, so don't be alarmed. If you feel your pulse is irregular, ask your doctor to check, and they can do an EKG, check a monitor, all those things. But if you have a condition called AFib, that also puts you at risk. And then that cryptogenic stroke falls in that category of AFib, because that AFib may not be detected for a long time to come. We have done a lot of studies. I was a part of that trial at Baystate when we looked at using medications beyond aspirin, beyond cholesterol medicines such as strong blood thinners, and we found that did not pan out. In fact, you're better off not doing those medicines if you don't need them. And obviously, if you do need them, we look for those. Cryptogenic strokes are an area of interest and research, and very often we may not find a cause. I always tell folks that when you're doing all these things to prevent a cryptogenic stroke and having a recurrent stroke, you're doing a lot of good things, preventing a heart attack, preventing vascular disease, and that's something that we are, always looking to improve on. But obviously, cryptogenic stroke is an area of interest right now, and I've not seen a lot of folks with cryptogenic stroke come back to us, but I do know that people who have cryptogenic strokes, we kind of tend to look at the risk factors just the same way from strokes of other etiologies or other causes that I mentioned now.
Thank you very much. The next is from Lisa, and it's more of a comment. She just wanted to say that in September of 2015, she had a stroke. She didn't know anything, and I'd lost control of my right side. And she said, Dr. Padmanabhan treated me for TPA, and I was completely cured with no residual effects at all. I wanted to take this opportunity to thank you for saving my life. 6.5 years and still no problems. Thank you so much, Doctor. Sincerely, Lisa.
Very kind of you. Thank you, Lisa. I appreciate that. I really hope this message goes across to everybody and you're doing the right thing. So thank you for being a participant and thank you for recognizing us. I'm truly humbled by that. Thank you.
I hope I'm going to read this next one right. This is Valerie. If someone has primary Moya disease and has had revascularization surgery and later has a stroke, how long does this change recommended response to the stroke, if at all? How would it change preventative measures would you recommend? And also, have you used forced hypothermia to help someone who's had a stroke? So that's a big one.
Yeah, a lot of tough questions, but I can tell you that Moya is less common. I didn't want to put it up there, but I brought it up in what we call the vascular diseases in young. Moya is a kind of disease that tends to cause progressive narrowing of the arteries as they get into the brain. And it was typically described in Asian population, but it's becoming more and more common across the world. Now, revascularization procedure, wherein people get a bypass from the carotid into the brain directly, that's growing collaterals, that's getting the blood into the brain. And very often it's a long process because the brain has to kind of get used to getting its supply, has to reroute. It's like a bypass, you're making a detour. So it takes a long time, months, maybe even longer. And when it comes to risk factors, we tend to not reduce the blood pressure too much, but I'm not entirely sure about lowering the temperature, which is called hypothermia. But I do know that, it's very important to treat fever vigorously and to prevent a fever. So that's very important. We cannot always prevent a fever, but if you're ill, seek advice because that does affect, your bodily function. And obviously, it's important to know that when somebody has this kind of complex procedures, your brain kind of responds differently. Each person is different. How long does it take? I really don't have a correct answer for that. It might take weeks, months, even years, because you're trying to open up new pathways that the brain has not seen before, and you're trying to tell the brain to find new ways to connect. So, it's a long process, and we have a lot of specialists in our system that can help get into more details. If you're seeing somebody, good. If you're not, let us know, and we'll be happy to connect you with our Moya specialist. Thank you.
Thank you. Just a couple more questions. I know we're at time, but if you have the time, Doctor, we could do two more. You're good with that?
Of course. Yeah, of course.
Well, first of all, Carol said thank you for the talk, and she appreciates you. And then this attendee wants to know, is there any connection between strokes and migraine headaches?
So that's an important question. And, the important thing about migraines and strokes is it's not a direct connection. There has been a lot of literature about migraines and stroke risk, and migraines with aura and stroke risk, and migraines with aura with birth control pills and stroke risk. The problem comes is the American Heart Association did this huge study that looked at those things, and the risk directly from a migraine is not well explained. I can tell you that migraine has a cross connection with other things. So some people may have a cross connection, say, with a PFO and clotting disorder, and they're taking a birth control pill. Or they have migraine with aura and they're taking a birth control pill that can increase the risk of clotting. Or they have migraine and they're smoking, or they have migraine and hypertension. That kind of has panned out more and more over the years. And we're seeing migraine as something that we are seeing as an innocent bystander, so to speak. I'm not saying that it's not entirely possible, but the risk is so less than having hypertension, diabetes, cholesterol, or taking a birth control pill, plus smoking, and all the things I mentioned earlier. So if you have migraine, you're not alone. There is, I think, about 70 million people in the US suffering from migraine. We are not seeing that many strokes, so there's a reason why. So we just want to make sure that you don't get worked up on that, but we do want to make sure that migraine patients have a discussion with their primary care doctor, especially migraine with aura, about whether or not they can take birth control pills, especially women. And in men, quit smoking, try to reduce drinking. So that's the important take-home message, because it's the combination of factors that make the stroke risk worse or the heart attack risk worse. So hope that answers. I have an actual number that the AHA puts out, which is 1 in 200 something thousand as a risk. But again, AHA also says that that risk is not directly attributable. There is another thing that's confounding it. So we have to take that with a grain of salt. And I have to say that, migraines are very common. It in fact runs in our family too, but strokes are not. So, so that's very important to know that, you're not alone. So.
Wonderful. Thank you. This is our last question. John said that he had a mild stroke. What are the odds I will have another stroke? P.S. I'm working closely with my doctor to have a good rehab.
Yeah, I mentioned one very important thing. 75 to 80% of all strokes are first-time strokes. This is good news. So only 1/4 of all strokes are second or third strokes. So generally speaking, when we talk about somebody's stroke, when you see us or when you see your primary care doctor, you're already making those decisions with the medications, the discussions. Everything that I mentioned that prevents a stroke today is also applicable to people who already had a stroke. So you're making those decisions. Your risk of stroke is way less than what it used to be when you have those discussions and management with your primary care, your stroke doctor, or your cardiologist, or whoever is seeing you to take care of those medicines. So my only advice is you're doing the right thing by seeing your doctor, taking care of those numbers, and taking those medicines. And that's important. Obviously, we can't beat it, but I can say that the risk is much less compared to the first-time strokes. So, and the reason why is you're kind of addressing it. Exact number, it depends on each person. Again, we have a lot of risk scores, and I don't want to get into it, but generally speaking, second and third strokes are less common than first stroke. So that's reassuring for us.
Excellent. Thank you. And we'll end there. I thank you, Doctor, for your time and expertise. Brilliant talk. Great Q&A session. Thank you very much for your time, and we appreciate the audience joining us.
Thank you.